Good morning, everyone. Next IC is on demystifying the chart. Score high on your exam table. This IC is mainly aimed at helping the residents to score high at their practical exam on the investigation session. We know that investigation charts will be kept both in OSCE and in practical, and also during the theory sessions. So first we have Dr. Anju Kuriakos talking about fundus fluorescent angiography and ICG angiography.
Good morning to one and all present here. I am going to talk about FFA and ICG. So, what is FFA? It's a fluorescent angiography which involves photographic surveillance of passage of fluorescent dye through the retinal and choroidal circulation. So, to know about this, basically we should know the anatomy of retina and choroid. Retina and choroid has dual circulation, which involves most of the retina supplied by the central retinal artery and choroid by the posterior ciliary artery, and the drainage is through the otex veins. So next thing we want to be aware is blood retinal barrier. We have two blood retinal barriers, inner and outer blood retinal barriers, which have tight junctions. So when the basic principle of FFA involves. One second. So basic principle of FFA includes emission and absorption and emission. So the absorption occurs at the 465 to 490 nanometers and the emission occurs at 530 nanometers. The light is passed through the blue filter, and the excited light is emitted with the yellow-green light and recorded in the camera. There are 5 phases of angiogram. First is pre-retinal phase. Next is the arterial phase. Next is arteriovenous phase. Next is the venous and late venous phase. The first is the pre-arterial phase, where we will not see any dye perfusion. The next is the arterial phase, where we can see the dye perfusion through the arteries, mainly superior retinal artery and the inferior. Next is the mid-venous phase and the late venous phase. The technique is the camera involves 35 to 200 degrees of field. Sodium fluorescent water soluble orange dye with low molecular weight is used. Most commonly used is 5 ml of 10% dye, and it is 70% protein bound and is excreted after 36 to 48 hours from urine. So this is the dye I'm talking about. It is a sodium fluorescent dye, water soluble orange color dye. So in the phases of the fluorescent angiography, first we will see about the foveal avascular zone, where the foveal area there is hypofluorescence. Dye is not seen in that area. What are the reasons for that? Is absence of blood vessels in the foveal avascular zone and blockage of background fluorescence by xanthophylls in fovea and RP cells in the fovea. This is the case of macular ischemia, where there is distortion and enlargement of the FAZ. So, in interpretation of the fluorescent angiography, there is normal and abnormal. So, in abnormal, we'll discuss more about the abnormal fluorescent angiography. There are two divisions, hyperfluorescence and hypofluorescence. In hyperfluorescence, there are four categories. First, it is leakage, pooling, staining, and window defect or transmission defects. Next is hypofluorescence, which includes filling defects and blocked fluorescence. There is one entity called as autofluorescence. It is the inherent property of a lesion to fluorescence spontaneously even in absence of dye molecules. It is commonly seen in optic nerve head drusen. Okay, you can see in this picture, this is a normal fundus photo and this is the autofluorescence photo. Next is a hyperfluorescence, an area of abnormally high fluorescence due to the increased intensity of dye molecules. It includes leakage. Leakage is intensity of the dye increases with the size. As you see in the picture, this is the first image showing only the intensity, and the leakage and the size of the dye increases. Intensity and size of the lesion increases as we go to the later stage. It is commonly seen in NVs in PDR and CSR. This is smokestack appearance in CSR. Next is pooling. In this, the area of the leakage remains constant. Intensity of the leakage increases with time, but the area of the leakage remains constant. It is example serous PD in CSR. Next is staining. Staining is no change in intensity or size. Next is window defect. It is increased fluorescence in choroidal phase itself due to the atrophy of the RP cells. Next topic is after hyperfluorescence, it is hypofluorescence. It is area of abnormally poor fluorescence due to the paucity of dye molecules or due to masking of fluorescence. It can be either non-filling or blockage. This is non-filling, and next is blockage, which correspond. How do we differentiate it? Is we have to keep a fundus camera before that, and you can see the corresponding blocked fluorescence of this pre-retinal hemorrhage in the FFA. Now, what are the complications of FFAs? They are categorized into three: mild, moderate, and severe. Mild is staining of skin, sclera, and mucous membrane, stain, tears, saliva, orange, yellow urine, skin flushing. Next is moderate, includes nausea, vomiting, urticaria, fainting. Next is severe, which includes laryngeal edema, bronchospasm. Next topic is ICG. ICG was first performed in 1972 by Flower. Performed the first ICG to image the human choroid. So properties of this dye is, it is a water-soluble tricarbocyanate dye, observes light in the near infrared range of 780 nanometers and emits fluorescent at 820 nanometers. The importance of this dye is it is 98% protein bound. Infrared property allows the penetration through the melanin pigments and blood, and excreted through the through liver. So this is a basic principle of ICG. Phases of ICG. It includes early phase, mid phase, late phase, and the elimination phase. Abnormal hyperfluorescence are called as hotspots. There are of two types. One is plaque, which includes more than 1 dd size, which has more than 1 dd size, corresponds to occult CNVMs, and focal hotspots less than 1 dd corresponds to RAP and PCV. So how does an occult CNVM on ICG looks? Late stainage of the abnormal choroidal vessels, and ICG for ARMD to differentiate type 1 and PCV. So choroidal tumor to identify the dual circulation. We can see the dual circulation in picture C and D. What is the basic difference between this FFA and ICG? FFA is mainly for the retinal circulation, whereas ICG is for the choroidal circulation. Sodium fluorescent is used in FFA, which is 70% protein bound and visible in the light into visible spectrum. Low molecular weight and blue-green filter is used. For ICG, its choroidal circulation, indocyanine green is used, and 98% it is protein bound, light of infrared spectrum, high molecular weight, and infrared filter is used. Advantages over FFAs: study of choroidal vasculature otherwise prevented by FFA due to RP blockage. Infrared is scattered less than visible light, so thus suitable for this media opacities. And ICG's 98% molecules are protein bound, so thus remain in the blood vessels for longer time. Thank you.
Thank you, Dr. Anju, for that a very informative talk. Next, we have Dr. Hema VK, who will be talking about ultrasound B scan. She is a vitreoretina fellow at Comtrust Eye Hospital.
Good morning, everyone. The B scan was first used by Mund and Hugh in 1956, and the main milestone comes when Osnick standardized the echography in 1960. Coming to the wider application of ultrasound, it is used in abdomen and orbit, as we know. In orbit, anterior segment is done with 50 megahertz and ocular is done at 10 to 20 megahertz. And the indications of B scan is done both in opaque and clear media. In opaque media, where we have a corneal opacity, hyphema, small pupil cataract, vitreous hemorrhage, and dense vitritis. And for clear media, for evaluating the choroidal thickness, intraocular mass lesions, optic nerve abnormalities, intraocular foreign body, tumors, and orbit and biometry. In this session, I'll be dealing mainly with posterior segment ultrasound. So the principle of ultrasound is dependent upon tissue acoustic impedance, which means that the velocity of sound is dependent on the density of the medium through which the sound travels. So when sound travels from one media to another of different density, an acoustic interference is created. Part of the sound is reflected from the interface between these two media back into the probe, and this is called the echo. So greater the density of the difference in the interface, greater the echo, higher the reflectivity. So the diagram shows this is the incident wave which comes from the probe. So part of it is transmitted through the wave to the other media and part is reflected, and this reflected is taken back by the probe, and this depends upon the density of the medium. The velocity is different in different medias. In aqueous and vitreous, it is 1532, and in silicon, it is 98. What difference it makes is that when we do a B scan in the silicon oil-filled eye, the axial length will be more because the sound takes more time to travel through the medium. Next principle is the angle of incidence. The more perpendicular the area of interest, the more maintained to achieve the stronger the echo will be. As the diagram shows, when the probe is kept perpendicular, the echo will be having a more appropriate spike. This is important when we do a B scan. Sometimes we feel that the echo is not corresponding to the echo of a retinal detachment and be confused that it is a PVD. But actually, it also depends upon how perpendicular the probe is going through the lesions. So it will depend between the observer or investigator also. Next principle is the gain. It indicates adjusting the application of the echo signals. Higher the gain, the more weaker echoes will be seen, but the resolution will be poor. Lower the gain, the weaker echoes disappear and only appears the stronger echoes. So it's better to start in a lower gain, and if you have any doubt whether the lesion is pathological, go into a higher gain. This is the our B scan machine, which indicates a gain what we are normally using, that is 110. And this is the patient when the B scan is done at 110 gain. But when the gain was reduced to 94, we can see that the abnormal echoes are reduced and only some few echoes are persisting compared to the previous one. Another phenomenon in B scan is time gain compensation. it indicates the process of enhancing the returning echoes from the deeper structure by reducing those from the structure closer to the surface. This can be used mainly when we are evaluating a orbital lesion. You can increase the time gain compensation and go more posteriorly behind the retina to see the lesion. So display of the B scan, we can see the A mode, B mode, a combination mode, and 3D mode in newer images, and some have color Doppler. And A scan is also called an amplitude scan. It is a single dimension scan, and the spikes indicates the amplitude or reflectivity of the echoes. B scan is the brightness scan, and it is a two-dimension scan, and it shows dot echoes, clump echoes, membranous echo, etc. And the strength of the echoes is decided by the brightness of the spot. So what does each spike mean? These are mainly asked in our exams. First spike is a probe spike, followed by a cornea, anterior and posterior surface of the cornea, then anterior lens, surface, posterior. Then we have next echo, the vitreous is a echoless median in normal young patients, and the retina spike, scleral spike, and orbital fat spike. Three types of probe position are there: axial, transverse, and longitudinal. The axial scan is done with the patient in primary position. The probe is centered at the center of the cornea. This scan is easy to understand, and the evident landmarks in the scan are lens and optic nerve. So when evaluating macular optic nerve, we'll be doing a axial scan centered in patient in primary gaze, centered on the cornea. So when we are given a chart like this, and you are asked which scan is that, the scan which have the optic nerve, macula, and capsule, that will be the axial scan. This question is mainly asked, usually asked in the exams. Next, it's a transverse scan. In the transverse scan, the patient looks in the direction of observer's interest. It is kept parallel to the limbus, placed in the opposite side where we are seeing. So when we are seeing the superior retina, or the probe is placed nasally or temporally, or when that is means that for vertical scan will be keeping the probe superiorly, and for horizontal scan will be keeping the probe nasally. Next is the longitudinal scan. In this, patient gaze is directed away from the probe towards the meridian being examined, and the probe marker is kept perpendicular to the limbus and towards the cornea. Usually it examines the anterior posterior slice of the globe. So this scan is used for examining the anterior posterior direction measurement of the tumors. The display of the B scan is usually a cluster of echoes. It can be either dot echoes or membranous echoes. Dot echoes or clump echoes are usually seen in vitreous hemorrhage, vitreous exudates, etc. And membranous echoes, RD, CDs. And the last one which we see will be choroidal retinal tumors. The differential diagnosis of dot echoes are degenerative vitreous conditions like age-related vitreous degenerations. They are low reflective and will be highly mobile. An asteroid hyalosis will be highly reflective, and there will be a space between the echoes and the behind retina. So most of the times this can be misdiagnosed as a PVD. A vitreous hemorrhage are dot and short line echoes which are freely mobile with moderate intensity, and sometimes the gain has to be increased, especially in fresh vitreous hemorrhage. And for vitritis, again, they are dot echoes which are moderate echogenicities and highly mobile. So when you are given a scan like this, you will have a confusion whether it is a vitreous hemorrhage or asteroid hyalosis. This this scan is not that confusing because you already have a membranous echo suggesting a PVD and a retro echo space. This is actually a VH, but even in cases whether you have a confusion, what you can do is that you can decrease the gain, and for asteroid hyalosis, since there is a high calcium content, the echo will persist even in low gain. This is a echo which is seen in clump, which is a typical echo of a vitreous hemorrhage. Sometimes there will be large number of dot echoes with highly mobile echoes with moderate echo density with adjacent thickening of the retinochoroidal scleral complex and suprachoroidal no echogenic or hypoechogenic space which comprises the T scan. This is typically seen in cases like inflammation like posterior scleritis or endophthalmitis. And when a scan is given like this, you can't say the diagnosis. You can say the differential diagnosis in the exam like posterior scleritis, VKH, endof, etc. So for endophthalmitis, you will get fine and dot echoes and membranous echoes of low and moderate intensity. And for these cases, you should also rule out if it is a penetrating trauma intraocular foreign body. And as we have told, there will be T scan and choroidal RCS thickening, retinochoroidal scleral thickening will be there. And some cases, choroidal detachment also is there, which shows that the eye is going to a pan-off situation. So as I have told, posterior scleritis will have a hypoechogenic area behind the choroid, and associated CD will be there, and in exam you will be asked other differential diagnosis which are VKH. And in cases with retinochoroidal thickening, you will be also asked the differential diagnosis for so you can you should also think about the other differential diagnosis like uveal effusion syndrome, etc. This is a hyperechoic clamp echoes with back shadowing. When this is seen in cases of trauma, we should suspect a case of intraocular foreign body. Membranous echoes can be PVD, RD, retinoschisis, choroidal detachment, etc. The main differentiating features between each is how the measurement of your spike is and also after movement. The after movement shows nothing, but when you ask the patient to move the eye and come into a stable position, the echo will persist moving. That is called good after movement. A good after movement is seen in PVD, but these are usually absent in RDs and CDs. And the other differentiating features is that an RD has a high reflective membrane, a PVD has a moderate or low reflective membrane. CD again has a high reflective membrane, but CD is thicker than RD. And also CD usually extend anteriorly involving ciliary body, unlike RD which stops at the aura. And in case of RD and PVD, how to differentiate is that RD usually have a uniform thickness, but PVD, even if at first whether we feel it is uniform, but in different directions of the gaze, the thickness will be uneven. And as we have discussed, the RD will have a mobile membrane, but less good after movements. But in chronic cases, the mobility can be decreased. But PVD has good mobile membranes and good after movements. The RD is attached anterior to the aura and posterior to the optic nerve head. PVD may or may not be attached to the optic nerve. When it is attached to the optic nerve, it is called complete PVD, and if it is detached, it is incomplete PVD, and if it is detached, it is called complete PVD. ARD, the spike will persist even in low gain. So this is a case which shows a moderate intensity spike with in kinetic BCN, it is highly it has good after moment suggestive of a PVD. This is an RD which is a hyperreflective membrane which is attached to the disc and low good after moments. You can also show some dot echoes in the vitreous cavity And this was actually a case of vitreous hemorrhage with retinal detachment. So choroidal detachment are usually thick, smooth, dome-shaped. They don't have an ONH attachment, and they have as RD 100% spike, low mobility. Sometimes the patient can have 360-degree CD and kissing choroid. And sometimes the choroid can be serous or hemorrhagic. In this case, if a case like this is given for your exam, you can explain that in this there is a membranous echo which has a high spike in the not extending up to the posterior pole seen in the periphery, and the internal echoes are non-echogenic or hyper-echogenic, which is suggestive of a serous choroidal detachment. Intraocular tumors is again a topic kept in exams. You can see the location, shape, size and number, surface characteristic, internal reflectivity,
Excuse me,
and
Dr. Hema.
associated features are important. Retinoblastoma has is irregular configuration with calcification with high reflective shadows, and the high reflectivity persists even in low gain. So you'll be asked other questions like DDs of leukocoria and what are the B-scan findings in them. And also other causes of intraocular calcification like retinoblastoma, cysticercosis, choroidal osteoma, phthisis bulbi, etc. This is a case of hyperreflective ring-like membranous echo with an hyperreflective internal echo with again a hyperreflective dot echo in clump suggestive of scolex. And this is a case of hyperreflective echo at the optic nerve head with a backshadowing suggestive of optic nerve head drusen. Choroidal melanoma, the pathognomic features is a collar button or mushroom appearance. If you see that, this is a choroidal melanoma until otherwise proven. It has high surface reflectivity with a low or moderate internal reflectivity. And also the internal reflectivity is homogeneous, and you will have an exudative retinal detachment. And the other feature which is asked in exam is positive angle kappa, which means a decrescendo fashion due to the high surface reflectivity and low internal reflectivity.
Excuse me, madam. Time.
There can be choroidal excavation, etc. So you will be when you are given a scan printout in an exam, practical exam, you can read from anteriorly to posteriorly like lens, whether it is cataractus, it will be densely echogenic internally, and whether it is pseudophakic, you will see iole vibration. Vitreous echoes, retina, choroid, optic nerve, whether it is normal or RCS thickening. These many points you have to see, and also you have to relate it clinically. So when B-scan is kept in the exam, you should think about the relevant clinical history, what the examiner has told. Read the findings, not the diagnosis. The examiner is expecting the findings, not your diagnosis. He already knows the diagnosis. So don't be over smart. Don't jump into diagnosis. You say the differential diagnosis and other relevant findings, what should be noted, like in vitreous hemorrhage, other like tractional detachment, IPCV or retinal tear, and how you will manage this case. These many points you have to think before you are attending the exam. Thank you.
Thank you, Dr. Hema, for that extensive talk. Next, we have Dr. Raki De Cruz talking about corneal topography. Over to you, Dr. Raki.
Good morning, everyone. Dr. Raki. So, I'll be talking on corneal topography. Corneal topography, as you know, is a very vast topic. It cannot be covered even in 1 hour. So, I'll just brush through the main points and help you with how to read in your exams. So, the history, this was started by Father Christopher Scheiner, who is a Jesuit priest. What he did was he tried to equate the reflections of a window pane on the surface of the cornea to that on a glass sphere of a non-curvature, thus getting a rough idea of the corneal curvature. This paved the way to the keratometer, which is based on the principle that the radius of curvature of the convex surface is directly proportional to that image that is formed by it. So the current topographers, what are we having is based on elevation based, and they are based on 3 main principles. So one is a slit scanning method, in which is the OP scan. Then comes to the Scheimpflug principle, in which runs the Pentacam, Ocalizer and Galilei, and then the high resolution KSOC2023 which is the Visande. So what is the Scheimpflug principle? So whenever we are taking a photo with a camera, the film plane, the lens plane and the copy plane, they are all parallel to each other. So this helps you get a good quality image. But if you change the lens plane in such a way that they are not parallel to each other, the point of intersection of these three planes produces an image which is of very good quality and with very good depth of focus. So essentially in a Scheimpflug imaging system, there is a camera which rotates 360 around the cornea, and it also has a blue light of nearly 470 nanometer to illuminate the cornea, and it takes around 50 scans in 2 seconds. A total of 25,000 elevation points are taken. Another important thing which you need to know is that all the data which is there in the corneal topography is color coded. So when it comes to green, it's normal. If it goes to the cooler color, that is blue, something is low, something is posterior, something is flat or something is very thick. If it is coming to the yellow red range, something is high, something is positive, something is very steep, or something has a high power, or some surface is very thin. So this is a OrbScan map. It is a chord map. Chord map means there is 4 maps within that. So the upper left is the anterior float, upper right is the posterior elevation map, upper down, the lower down left side is the curvatural map, and lower right side is the thickness map. So this is how a OrbScan printout will look like. Most of the previous hospitals has the OrbScan only, but the newest, the technological hospitals have the Pentacam. So mostly you will be given this printout only and asked to say how what is there in that. So in the middle you can see there is something which has so many values are written in that. So that gives the SIM-K astigmatism. Here you can see like here you have the SIM-K astigmatism, which gives a total astigmatism. Then there is the K values, K1 and K2. Then you have few values for the 3 millimeter zone and 5 millimeter zone. What you want to remember is, you can see something like this here, no? Irregular in the 3 millimeter zone. So that irregularity in the 3 millimeter zone, if that value is greater than 1.5 diopters, this scan is abnormal. Similarly, in the 5 millimeter zone, if the irregularity value in the is more than 2.5 diopters, that is abnormal. So in the 3 mm zone, if it is greater than 1.5, and in the 5 mm zone, if it is greater than 2.5, it is abnormal. And it also gives the thinnest Paki which is there in that scan. So what are the clinical applications? This is mainly used in refractive surgery patients and in following up of ectatic disorders, keratoplasty, in contact lens fitting, and for ICL planning. So before reading the map, you have to identify the color scale. Sometimes it will be an absolute scale. There will be a set gradations, but sometimes it will be a normalized scale. So you have to look at the scale in the left corner. Then you have to assess the image quality, whether it is okay or not. Also, you have to consider a few additional considerations like the age, between eye symmetry, etc. Now coming to the concept of the best fit sphere. So what is the best fit sphere? Whenever the computer takes an image of the cornea, it tries to calculate a hypothetical sphere which is almost similar to the cornea that is being examined, and tries to fit it into that cornea. This is known as the best fit sphere. So normal cornea is prolate, so there is a center area of warm colors, and then surrounding an area of cool colors, that is blue, and in the periphery again there is a set of warm colors to the peripheral highlands. Coming to the thickness map, in the thickness map what you want to look is the superior inferior asymmetry. The superior value and the inferior value, if the asymmetry is greater than 30 microns, it is abnormal. In the curvatural map, look for skewing. Skewing means when compared to the optical axis, if there is a skewing more than 22 degrees, it is again a red flag sign. Also look for abnormal shapes like butterfly, crab claw, vertical D. These all are abnormal. I'll be discussing them later. So these are different shapes that are possible in the elevation maps. So here down you can see F, concentrate on F. F is a symmetrical bow tie. When coming to G, it's a symmetrical bow tie but with a skewing. H is a symmetrical bow tie with inferior steepening. I is the one with superior steepening. And J is the one with an inferior steepening and also a skewing. So the difference in Pentacam. Pentacam is like a 5-in-1 innovation. It has a Scheimpflug camera. It has a 3D anterior chamber analysis, pachymetry, topography, and even a cataract analyzer. The main difference is that there is a rotating Scheimpflug camera. Along with that, there is a static camera also. So this is how you get the map of a pentacam. You have a chord map similar to the OBSCAN itself. Then in the left hand side, you have a set values. So first you have to check the quality of the scan. So the quality is given here. Can you see here? QS. The quality has to be okay. If it is in the color red or if it is in the color yellow, then the quality is not okay and you are supposed not to read that scan. Then look for the K1, K2 values. K1 is a flat meridian, K2 is a steep meridian. So if this value is greater than 47.2, that is abnormal. Then there is a K mean. Similarly, there is a corneal front elevation data and a corneal back elevation data also. Then there is something called as a K max, which is given down to this. So if that value is greater than 47.2, it is abnormal. 48 to 50, moderate chances of keratoconus. Greater than 50, high chance of keratoconus. Coming to the Q value. So here you can see something like Q value. Just beneath the QS, there is a Q value. So the normal Q value is between 0 to -1. Greater than 0 that means it's a flatter cornea. It's an oblate cornea. If it is less than 1, that means it is a steeper cornea or the cornea that can be ectatic. And also in the curvatural map, you have to look for the inferior superior asymmetry greater than 1.5 diopters. Coming to the elevation maps in Pentacam. So here in the right hand side, you will be having a front elevation map and a back elevation map. So if the anterior elevation map, any value greater than 12 is abnormal. In the posterior elevation map, any value greater than +18 is again abnormal. And the difference between the front and the back should be less than 5 microns only. Coming to the thickness map, first you have to locate the thinnest reading on the elevation map. So here, this is the thinnest reading on the elevation map, and then you have to compare it with the thinnest point in the pachymetry map. If that value is greater than 470 microns, then that is abnormal. So Pentacam has a Bellin-Ambrosia enhanced display map also. So what is different here is that rather than the best fit sphere, there is something called the best fit enhanced sphere. So the normal best fit sphere tries to contain all the ectatic areas also within that sphere. But what if there is a keratoconus and there is a projection? So here comes the role of the best fit enhanced sphere, in which it tries to exclude the 4 mm area around the region of ectasia. So that is a best fit enhanced sphere. So this is how the printout comes. Look at this side. So here, this is the value which is given by the best fit sphere, and down these two are the values given by the best fit enhanced sphere. So finally, subtracting these two, here you get the final map. So if everything comes in green, it is normal. Something in yellow or red like this means that is abnormal and there is chance of thinning. Coming to the graph which is there in the Pentacam. So this is a thickness profile gap. There is two values in that, the corneal thickness spatial profile and the percentage thickness profile. And there are 3 dotted lines. The center dotted line is the one that is normal. Above and below are 2 standard deviations, above and below the normal. So whatever is there in the red is the tested cornea's value. So ideally it should coincide with the normal center one. But if it is coming down like this, in this scan you can see the tested cornea's values are way below the normal set standards. That means there is some issue with it. It is ectatic. And if the corneal thickness dips way below the 6 millimeter, this is a 6 millimeter point. So if it dips below the 6 millimeter, that is called as a quick slope, and it is highly suggestive of keratoconus. There can be other shapes also here, like an inverted shape will be there, that is seen in pellucid marginal degeneration, a flatter one which is seen in case of Fuchs or Gutte. And finally, we have the progression index also available in the pentacam. Main thing we have to concentrate is the ART max value. So this is given at the last point. So if the ART max value, if it is less than 400 micrometer, that also means there is a high risk of ectasia. So let me just discuss one or two slides on keratoconus. So this is a slide of OpScan of keratoconus. So when you are trying to read this, you have to say first the quality is okay. Since astigmatism is around 2.6 diopters, and coming to the K values, you can see this value is greater than 47.2. So there can be this value is suspicious of a chance of keratoconus. And now coming to the curvature map, you can see that there is a asymmetric bow tie is there with an inferior steepening. So this can be a case of keratoconus. Similarly, there is a next case where there is much more skewing. Skewing is there, which is greater than 22 diopters. So this is a definite case of keratoconus. And then there is asymmetric bow tie with inferior flattening. These all are cases of keratoconus. And what is this? This is something different, right? Center part is flat and the peripheral part is steep. Center is flat, giving cool colors, and periphery is steep. So this is something opposite to the normal cornea. So what is this map suggestive of?
Excuse me, Ragi, we are going out of time.
So this is suggestive of a post-refractory surgery case. The patient has already undergone a LASIK. That is why the center has become flat. PMCD gives a peculiar crab claw appearance. Another in cases astigmatism. Astigmatism, you have to mainly check the astigmatic value between the two eyes, and if it is greater than 1 diopter, again this is considered as a red flag sign. Thank you.
Next we have John Davis Akere speaking about HFA and OCT in RNF.
So, good morning, everyone. I'll be giving you a quick guide to HFA and glaucoma OCT. Okay, so I'm Dr. John Davis Akkara. What is a visual field? It is an island of vision or a hill of vision, and there is this gap in between for the blind spot. And it has applications in neuro-ophthalmology and glaucoma. Neuro-ophthalmology, we are not going to look at it right now. Glaucoma, you confirm the diagnosis, you follow up for progression, and you check the efficacy of treatment. And this is the instrument design of the HFA. You have this decibels refers to the retinal sensitivity, and apostims refers to the brightness of the stimulus. So they are inversely related to each other. Okay. And stimulus duration is 200 milliseconds. Background illumination exam question 31.5 apostims. And the location is more important to know where the patient is looking at the moment of the stimulus presentation. And monitoring is done by the Heil-Krakow method, where a stimulus is given at the blind spot where the patient is not supposed to be able to see. If the patient sees a stimulus at the blind spot, that is counted as a blind spot visualization. So that is counted as an error. Okay, and there is also a gaze tracker which looks at the pupil position. And the most useful program for established glaucoma is to do a CETA fast 24-2. You can do a 30-2, but it will just take more time. Patient will get more fatigue. And for an advanced glaucoma, CETA fast 10-2. And now it has been shown that 10-2 is useful also in a moderate glaucoma. And for a pre-perimetric glaucoma, where you are not sure the patient has glaucoma or not, you can do a full threshold. You can do a fastback, you can do a swap, okay, blue on yellow swap program also. And so 10-2, it is covering central 10 degrees, it has 68 points. It covers the macula and is useful for advanced glaucoma, also retina and neurological cases. 24-2 central 24 degrees except nasally, which covers 30 degrees, 54 points. 30-2 all around 30 degrees, so it has more points, 76 points. And there is also a 60-4 which covers the periphery. Okay, that is far periphery, 30 degrees to 60 degrees. And you can also check the nasal step. And there are 1.2 million neurons and 3000 neurons annually die, and 20 to 40% neuronal loss is required to produce a field loss, visible field loss. Okay, so it's not a minimal thing, it's 20 to 40%, but in swap 10% neuronal loss can be visualized. Okay, and it starts as a localized field effect, progresses to a diffuse field effect. And I will show you that localized ones are for glaucoma, generalized can be due to cataract or media opacities or even meiosis. This is how a field looks like. So first section is the patient data section, and then the reliability indices and the patient sensitivity. So this is the raw data and this is the representation. And then there is of course the pattern total deviation here and the pattern deviation here. And then you have the global indices, visual field index and all that, and the glaucoma hemifield test. We'll look at each one in detail now. Patient data, it also measures the pupil size and the demographic data. Refractive correction has to be entered. Date of birth has to be entered correctly because it uses the database for normative data. And the reliability indices, you have to look at fixation losses. This is done by Hale-Krakow method, blind spot monitoring. And also false positive should be less than 15%, false negative should be less than 20%. Very easy to look at it. If it is more, it will put a double X mark next to it. Okay. And yeah, this is just telling you that there is double X mark if it is more. And patient sensitivity is measured in decibels, and so this is the sensitivity. This is the raw data, and after the raw data you get the total deviation here. Total deviation raw data, it is represented here, and this is after subtracting the seventh largest point, and you get the pattern data. So this can be due to anything, cataract or media opacities or even meiosis, and this gives you localized effects. So whatever is seen in the pattern deviation is what is representative of glaucomatous field effects. And you adjust for sensitivity with age, that is why the entering the age is important. And these are the global indices and mean deviation and pattern standard deviation. We'll not go into the details of that right now. This is the glaucoma hemifield test. This looks at the both the upper and lower sections and looks for any loss of symmetry. If there is a loss of symmetry in these quadrants, then that shows up as a glaucoma hemifield test abnormal. So within normal limits, outside normal limits, borderline, or generalized decrease in sensitivity, abnormally high sensitivity, or low patient reliability. These are all the outputs which can come from the glaucoma hemifield test. And of course, it's for diagnosis of glaucoma Anderson's, you also have to look at the glaucoma hemifield test and the cluster of 3 or more non-edge points in a 30-2, or if it's a 20-2, a 24-2, you can consider the edge points also with a p-value less than 5%, at least one of which is a p-value p less than 1% on two consecutive fields, because fields are not very reliable. You have to check it on at least two consecutive fields. So this is again the same one. A cataract, there is depression in the total deviation but not in the pattern deviation. Cataract, corneal opacity or meiosis. Okay. And this is a swab test, blue and yellow, and this can detect pre-perimetric glaucoma. If there is even minor changes, up to 10% to 20% neuronal loss can be detected here. And this is one way of looking at the progression. You can also look at, I'll skip these. Yeah, as a progression, you get an overview printout. You can do the glaucoma change probability analysis and change analysis. In change analysis, it gives you these triangles. Open triangles are improving. There are no open triangles here, and the dark triangles are depressed points. So you just, yeah, there is an open triangle here and there is a dark triangle here. All the others are dark triangles. Okay, so that is how you can do the this thing. Yeah, octopus perimetry is another perimetry. Zeiss had the upper hand, so that is not very commonly used octopus, but this is what an octopus perimetry looks like. And it's very similar. This gives us a grayscale map, which is not a grayscale, which is a color map in octopus. And here the numbers gives you the sensitivity threshold. The black squares gives you absolute defect. Nothing was seen by the patient in those points. And this is the raw data, and this is the not grayscale, this is a color map. And you get the difference, and that is what is sensitivity loss. Okay, so that is what it looks like, and it gives you the BB's curve so that you can see the defect curve there. So that is what it looks like, and we'll go on to OCT quickly because visual field has poor repeatability and reliability. OCT, because structural loss precedes the functional loss, but functional loss is what is more important. I'll leave this part. You have to look for the RNFL. So you look at the RNFL, you first see whether the segmentation is correct on the scans here, and then you see whether there is any artifacts here. If there are no artifacts and the segmentation is correct, then you look at the disk area and all that. And if the disk area is not too big, it's a normal sized disk, then you look for RNFL thinning in the various quadrants and clock hours. Due to lack of time, I think I will stop with this. Okay, there's also the ganglion cell complex. So you have to look at the GCC at the macula, which gives you earlier detection, but the more reliable more reliable one is obviously the RNFL. GCL gives you more sensitive tests. Thank you.
Good morning, everybody. So I'll be talking about OCT macula. For want of time, I'll be going a little faster. On the text slides, I'll be going a little faster in the text slides. So as we all know, optical coherence tomography or OCT, the basic principle is basically the low coherence light source which is there, which goes to a coupler, gets split and goes to the sample arm, that's the tissue which we want to examine, and then one goes to the reference arm. So when it comes back, it has a small difference or interference. So this interference is detected by the detector and gives the image. So this is the basic principle. That's a Michelson's interferometer principle. So evolution, when you go to see, it was 1971 when we started seeing inside the tissue, and then by this time we have got many other principles, that is time domain, spectral domain, and swept source. The most recent being the swept source, which gives the best resolution until compared to the other ones, which is almost the 5 microns. The speed of acquisition is also more, and the wavelength is 1050 nanometers. So this is the evolution, and then what are the protocols of scanning? That is the parallel line scans over here, which you can see is a raster scan. Then we have the radial scans, which is in a radial fashion, in a circular fashion, and then we have the 3D scans. That is macular cube or 3D cube kind of a scans. So how do we take OCT scan? We need at least a pupil diameter of 3 millimeters. Select the scanning protocol, keep it straight to the fundus, and then center the fovea or center to the area of interest. Once that is done, you can have a click, and then you get the OCT scans, which can be analyzed for qualitative and quantitatively. So next thing is, how do we interpret? So one is, you need to see if the patient name is proper, age and sex, If it's not the same name, then you might be injecting some other patient. So you need to be sure that you are having the proper name and the same person. Identifying the eye. So basically, the nasal side we have the PMB nerve fiber layer, which is a little more thicker, which I'll be showing you. And then signal strength should be maximum, and direction of the scans also should be noted. So going for the normal OCT, like I said, first we need to know what are the hyperreflective bands. As you can see, all these are noted here. Hyperreflective zones, hyporeflective and hyporeflective zones, and choroidoscleral junctions. So these are all the things which fall under it. And then the other classification which you need to know is reduced reflectivity and increased reflectivity. So these are all the things which we see in the OCTs. So once you know about this, it will be easier when you see a scan. So another thing is the older versions you should get a false coloring code. So high reflectivity you should get red, moderate high you should give green or yellow, and the hyper reflective is to be blue or blacks. So when you see another false colored OCT, you should know which one is what. So here you can see this is the left eye, because the nasal fibers are coming on this side. Okay, so this is what how you identify which eye. So this area you have to see, and then these are all the hyper reflective. This is hypo, this is hyper, this is hypo, this is hyper. So all of these you can actually understand by taking the normal retinal fiber anatomy. These horizontal fiber layers, horizontal tissue give a hyperreflective, rather than these cells which are radially placed, that will give you hyporeflective scans. And then we have this ISOS junction, which was previously named under the international nomenclature. This is basically the inner segment and outer segment of the photoreceptor layer, which is also being called as the ellipsoid zone. The ellipsoid zone has a hyperreflective layer, mainly has the mitochondria. What is a normal line scan of OCT, which has a normal vitreoretinal interface, normal retinal morphology, normal foveal contour, and normal inter photoreceptor layer, that is ISO junction or ellipsoid junction. These area are hyporeflective areas. These are moderately hyperreflective. These are highly hyperreflective, that is hyperreflective. And then we have areas of after shadowing, because it is a few of the lesions take up the hyperreflective and causes a after shadow. And then hypertransmission, wherever the retina is thin, there is higher light going to the choroid, so then we get a hypertransmission. So these things you need to know when you interpret a OCT. So where are the lesions which you can tell? That is, one is in the preretinal, one is the epiretinal, intraretinal, and subretinal. And in subretinal you have the subneurosensory retinal and sub-RP level. So whenever you describe a lesion, you can put into all these things. So what are the ones which comes in the pre-retinal spaces? Over here you can see this is the pre-retinal space. You have an incomplete PVD over here, right? And then we have vitreous cells. In this image you can see vitreous cells over here, hyperreflective dot kind of a lesion. That's all vitreous cells over here. And it is very important to even differentiate these cells with the vitreous hemorrhage sometimes over here, like how you can see in this DR case. Then we have the vitreoretinal interface. One of these are vitreomacular traction and adhesions, like you can see here. Focal VMTs are the ones less than 1500 microns. Broad VMTs are more than 1500, like over here. And then you can see this one. This is the posterior cortical vitreous, which has a traction towards the macular foveal area. Here you can see there are multiple vitreous planes. So these are all vitreous sizes which we can see in mostly diabetic cases. Then we have epiretinal membranes. So these are the classification for epiretinal membrane. Over here you can see a hyperreflective line kind of a lesion. This is a ERM, epiretinal membrane, which is being seen over here. And when it increases, when the epiretinal membrane starts pulling the foveal area, you can get macular pseudo holes. Like over here, this is a pseudo hole. It's not a full thickness macular hole. And then when there are intraretinal spaces like over here, you can you name it as a lamellar macular hole. And then we come to the full thickness macular hole. In the first few stages, it is more of a vitreomacular traction, which then develops to a operculum.
Time up.
Yeah. Operculum. There are other lesions of intraretinal, subretinal, and outer retinal, like diabetes macular edema. You can see over here, these are a few of the biomarkers. Intraretinal cyst, this is the bridging retinal process. And then you have central subfield retinal thickness. So these are all the biomarkers you need to see in a diabetic macular edema case. And then we have drill, disorganization of retinal inner layers, ELM and EZ disruption. It's a pearl necklace sign, which is seen in a chronic case. Intraretinal hyperreflective material. These are also indicative of at least 6 months old diabetic macular edema, which has poor prognosis. Then we have a hard exudates with the backshadowing. Then taut posterior hyaloid. I think it's time up for the next session, so probably I'll stop here. Thank you.
Thank you. Thus, we come to the end of the session.